Shresh, could you discuss how the availability of these newer options will impact the care of your patients with advanced GIST? In particular, how Intrigue and Invictus will be helpful in the context of current options, unmet needs, and who would you consider the use of ripretinib in, and at what point in therapy?
Absolutely. So I think at the outset, it's important to just say that we are all excited about having yet another effective agent that's relatively manageable in terms of toxicity profile and improves patient quality of life parameters. And that would be ripretinib for the fourth line setting KIT mutant GIST population, right? The label suggests that label indicates that that would be the population that we would use in. We've already discussed the fact that there would be good merit for that drug's use in earlier line settings. I think the data from the Intrigue trial will clearly help us define that a little bit better. In general, I think as everyone on the call realizes, as long as we have an approved agent for a given disease, the exact line of therapy in terms of standard of care practice may not necessarily be strictly adhered to. So to what extent will ripretinib start getting used in earlier line settings is an open question that remains to be seen. The Intrigue trial results will definitely impact on whether or not that happens. From the avapritinib standpoint, I think, again, it's commercially available for the D842V mutant population where it is the standard of care treatment. I think, would that drug be used off-label, if you will, in KIT mutant GIST? I think there's certainly a possibility. It would be nice if we could fine-tune the biomarker where it has the most activity. And I think, like you alluded to earlier, it's going to take a little more work to try to answer those questions. But in the meantime, I think having two new agents in the therapeutic armamentarium that allows us to treat these patients is very helpful. Over the years, what has happened to the natural history of this disease is that the drop-off rates from first line to second line to third line to beyond lines is slowly drifting away. That is, I think, as you mentioned earlier, Andy, we're getting better at proactive management of toxicities of the drug. We're getting better at proactive management of tumor-related symptoms, thus allowing us to continue some form of the kinase inhibition in these patient population so that they can live longer.
This has been extremely informative. Thank you, Dr. Patel, for this insightful discussion. And thank you to our audience for watching this targeted oncology presentation on precision medicine. We hope you found this discussion to be useful and informative.